Good afternoon and welcome to the City Club of Cleveland. My name is Paul Harris and I am president of the City Club's Board of Directors. I'm very pleased to introduce today's speaker, Dr. Stephen Stack, president of the American Medical Association. The American Medical Association, or AMA, was founded in 1847 when 250 delegates from 28 states met in Philadelphia. That sounds a bit familiar, doesn't it? To establish an organization dedicated to scientific advancement, standards for medical education, launching a program of medical ethics, and improved public health. During its 168-year history, the AMA has continued its focus on those founding principles. Today, its areas of strategic focus and furtherance of those principles are threefold. First, improving health outcomes, including preventing type 2 diabetes and heart disease. Second, creating the medical school of the future. And third, creating thriving physician practices by working with doctors to enhance practice efficiency and professional satisfaction and to improve the delivery of care. Today's presentation at the City Club of Cleveland continues our discussion of healthcare dynamics, a discussion that has included the impact of the Affordable Care Act, the commitment to the patient experience, the advent of electronic medical records, and the ongoing structural reform in payment and delivery models. At a time when technology seems to govern so many aspects of our lives, including how we interact with people, a core aspect of healthcare, the patient-physician relationship, sometimes seems challenged. Dr. Stack will discuss that relationship today. He has worked for 2 decades in emergency medicine and as an elected leader for medical associations at both the state and national level. He was born and raised here in Cleveland, Ohio, and attended the College of the Holy Cross in Worcester, Massachusetts, where he graduated magna cum laude. Dr. Stack then returned to Ohio for his medical school and emergency medicine residency training at The Ohio State University. He began his clinical practice in Memphis, Tennessee, and later moved to Lexington, Kentucky, where he resides today with his wife, also a physician and an AMA member, and his daughter. This past June, Dr. Stack was named the 170th president of the AMA's Board of Trustees. Now, I think I read that you were the second youngest or the youngest since the 1850s, and I didn't believe it until I actually met you, but now I believe it. Among his talents, Dr. Stack has brought health information technology expertise to the board and has led multiple AMA efforts in that area. So please join me in welcoming to the City Club of Cleveland, Dr. Stephen Stack, President of the American Medical Association.
Thank you very much. It's great to be here. It's great to be with a proper Ohioan, too, who knows it's The Ohio State University. Being here today really does bring back a lot of fond memories, the first of which that I didn't anticipate is I worked in that Ameritrust building, which is now a grocery store. So what a big change. I came down here, a family friend got me a job there, and I came work 2 summers, the start of my high school right there, and took the Rapid right down to Terminal Tower and walked down the street right to work every day for 2 summers, so it's good to be here. It makes me think of a lot of summerhood fun at Lakewood City pools, Friday nights at Winterhurst Ice Rink, skating to oldies music, the Metro Parks, the Cleveland Museum of Art, Severance Hall, countless hours at the Korean Karate Center on Madison Avenue in Lakewood, which probably not many people here would know about, but I spent a lot of my young life there. And then riding the rapid transit to get to St. Ignatius High School and doing the trip in reverse at the end of the day and stopping at the West Side Market with all of its wonderful smells and exotic foods. It's really, really good to be back here, and I appreciate the opportunity. And I want to thank the City Club for its century-plus commitment to informing, connecting, and motivating citizens. Thank you for all you've done for 103 years to facilitate enlightened dialogue in the community. And so now let's talk about doctors, patients, and healthcare in the United States. It was 3 a.m., Christmas morning, 2010. A young man in his early 30s came into the emergency department. He'd been working at his computer when he noticed an odd feeling in his back, something unusual enough that he decided to get it checked out. It turned out he had an uncommon but commonly catastrophic condition, a thoracic aortic dissection. If he didn't receive immediate and aggressive surgical care that day, he would invariably die. Since my hospital was unable to provide the necessary surgery, we had to transfer him to another facility. As we were getting him ready for his ambulance ride, fully aware of the danger he faced, he said to the nurse, "Please write down a phone number." He then said, "If I die today, I want you to promise to call my girlfriend and tell her I'm sorry we argued last night." Now, in this script, which I don't usually use scripts, I get a little emotional telling this, and this is a long time ago now for me. This is 5 years ago. So as we were packaging him up and getting him ready to go in the ambulance, all of us were in tears. Well, he didn't die. Due to our prompt diagnosis, the great skill of a surgeon, and numerous other clinicians, doctors, nurses, and others providing excellent care for him, he recovered. It's a stirring example of a great save and a triumph for modern medical care. 1 year later, to the very day, he quietly walked into our emergency department and said, "Thank you for saving his life." So I've told this many times, and like I just said, I struggle to not shed a tear sometimes, and when I tell it a little more drawn out and dramatically, usually I can get a whole lot of other people in the audience to cry while I'm doing that too. But this is just one example, just one, of the amazing power of the doctor-patient relationship. Clearly, he and I have left indelible impressions on each other's lives. This relationship is characterized by trust, mutual respect, vulnerability, and empathy. And it's a relationship I'll explore here today against the backdrop of another story, the story of healthcare in the United States. Healthcare in the United States is big business. Close to $3 trillion, nearly 1/5 of our entire gross domestic product flow through the healthcare sector in the United States. As a percent of the federal budget, roughly 1/4 out of every dollar is spent on healthcare services. Compared to the other developed nations in the world, on a per capita basis, we spend nearly twice the average of all the others. Yet for all this cost, as recently as 2008, 1 in 7 Americans, nearly 47 million among us, were without health insurance. And this continued to increase year over year as costs continued to rise, as employers dropped coverage, and as employees lost their jobs in the Great Recession. In fact, by 2013, Gallup found that 18% of adults were uninsured. This was clearly unsustainable and unacceptable for our nation. Then in 2010, the Patient Protection and Affordable Care Act, ACA or Obamacare for short, became law. The legislative process divided the nation in one of the most polarizing national dialogues in generations. And that polarization continues today. There are many reasons to discuss and even debate the law. Its impact on who we insure, how we insure them, and how we address the high costs of healthcare are just some of the most obvious. For many, though, the central difference of opinion is one's view of the proper role of government in their lives. The law has undeniably produced many results, however, and I'd like to highlight just one metric for now. 18% of Americans 18 and older were uninsured in the fourth quarter of 2013, just before the law's individual mandate, Medicaid expansion, and health insurance exchanges came online. Just about 18 months later, in the second quarter of 2015, Gallup now reports that 11.4% of adult Americans are uninsured. That's more than a 6% absolute reduction, or a 33% reduction in proportion of uninsured adults in the United States. This is a big deal. You see, in America, those without insurance live sicker and die younger. It's paramount, then, that we get all Americans into an organized system of health care while we concurrently work to improve that system so it consistently produces high-quality outcomes at a cost we can afford. As we navigate this journey of healthcare transformation in the United States, it's imperative that patients and doctors work hand in hand to preserve the centrality of the doctor-patient relationship as the necessary foundation for our success. Dating back to antiquity, when physicians had scant understanding of the workings of the human body and even less available by means of which to help their patients, they were a source not only for expertise, but perhaps even more importantly, for hope. You have all heard the statement, "As long as I have my health." That saying concisely captures the integral link between people's vitality and their personal happiness and productivity. It also explains the enduring value of physicians as partners with patients in their pursuit of vitality and the special bond between patients and physicians. This bond emerges from our deep human need for someone to give us reassurance in our time of fear and hope in our time of desperation. Thankfully, with contemporary medical and surgical care, we can now also provide treatments and cures in addition to comfort and solace. In 2004, when I was in Memphis, Tennessee, a fellow physician came to the emergency department seeking help for abdominal pain. Peter was in his late 50s or early 60s, had some new and nagging discomfort in his lower abdomen, and had decided it was time to get it checked out. He and I were both fairly certain he had diverticulitis, a common infectious and inflammatory problem of the colon, usually easily treated. When the CT scan was read, however, it turned out he had an uncommon form of cancer, and it had already spread throughout his abdomen. With this discovery, I had the unpleasant obligation to tell my fellow physician that rather than a minor illness, he had a grave condition, one that would require complex and prolonged treatment, and for which recovery was uncertain. Sitting on the edge of his bed, I walked him through the findings and discussed what we should do next. It was a rite of passage for me as this senior physician colleague placed his trust in his junior physician colleague. It was a particularly striking example of the physician become patient and the power of the doctor-patient relationship at work. Here, the patient was a physician himself, a uniquely knowledgeable patient, who needed and wanted the partnership, the support, and the reassuring presence of another physician to guide him through his time of fear and need. Here too, as with my earlier story, the relationship was anything but one-sided. I've already shared that it was a rite of passage for me as a junior physician caring for my senior colleague. It was much more than that, though, when taken from the perspective of a physician caring for his patient. You see, I set him up with a terrific oncologist before he left the emergency department. Peter followed up promptly and received excellent care, and his disease was put into sustained remission. For many years thereafter, I received an annual letter from him. On December 15th, 2008, he wrote, "Dear Dr. Stack, I write to once again acknowledge your considerable role in the miracle of my life. I remain in remission for what is now in excess of 4.5 years with no restriction. Please know that your kindness and expertise are a vital part of my gratitude. Best wishes to you and yours for Christmas and the new year. Sincerely, Peter." Remarkably, even when I moved from Memphis to Lexington, Kentucky, those letters kept coming. He somehow found a way to find where I had moved to. The letters kept coming, and when I got elected to the AMA's Board of Trustees, I got a congratulations letter from him. So even in the emergency department, we formed these bonds. And I point out to you that I'm telling this story more than a decade after I met him. Peter's own words and actions reflect the impact I had on his life. His impact on mine, albeit of a different nature, is no less influential and enduring, and I'm indebted to him for it. As a physician, I believe it's important for patients to hear stories like this, because it is representative of physicians in general. I'm not unique in my need to be connected to my patients and to be afforded the opportunity to focus on their well-being for the sustainability of my medical career. Following from this, and in the midst of tumultuous changes occurring in healthcare, the AMA wanted to investigate how physicians are feeling and coping. Through a partnership with the RAND Corporation, we found that physicians are overwhelmed by change and by intrusive regulation. The study also found, though, that physicians are renewed, refreshed, and motivated when at the end of the day, they feel their work has helped patients to lead healthier, happier lives, and that the health system supported them in that work. In fact, the number one driver of physician satisfaction, by a long margin, is the physician's bond with patients. In contrast, simply said, things that get in the way of them helping patients are the primary drivers of physician dissatisfaction. This is a wonderful affirmation of the commitment physicians have to their patients and the strongly personal bond we have with them. In this context, let's consider the changing healthcare landscape through the lens of technology. Fantastic advances in genomics, personalized medicine, minimally invasive surgery, sophisticated medical imaging, and countless others have revolutionized healthcare. Never before has the physician had access to more amazing tools to help their patients. In fact, previously terminal conditions like HIV, AIDS, and cancer are being transformed into chronically manageable conditions. If I could spend hours talking on these advances today, I'm going to focus on the revolution in digital health. So I like to do this sometimes. How many of you have something like this in your pocket? Is there anyone who doesn't? Don't raise your hand. Congratulations. You're a rebel. So practically speaking, every single one of you now holds the totality of human knowledge in the palm of your hand. All right here. When you seek medical care today, unlike the patients of antiquity, or even 1980, for the St. Ignatius table, I'm assuming right over here, the opportunity to reduce information asymmetry between the patient and the physician is incredible. More than any other time in human history, patients now gather their own information, collect their own health data, seek solutions from a variety of sources, and come to their physicians eager to discuss options, ideas, and treatments as partners with their physicians in creating health and well-being. This seismic change in information availability is both wonderful and fundamentally challenging to the doctor-patient relationship. Gone are the days when the access to accurate, comprehensive health information was limited to physicians, and the primary and the only source of it was likely to be a physician. Today, patients can come to the office with their own research, their own ideas, and their educated questions. Today, technology also enables people to track much of their own health data: how long they exercised, how well they slept, their blood pressure, their BMI, their blood sugar, and countless others. From Fitbits to telemedicines, patient portals to electronic health records, email to apps. We are all gathering data and information about our health and engaging with physician-led teams of experts to improve our health. In many cases, this is creating positive feedback loops and is empowering individuals to drive their own destiny in partnership with physicians and patients. Even in this rapidly changing landscape of healthcare delivery, financing, and technology, the doctor-patient relationship remains at the epicenter of healthcare. This intimate and precious interaction between these two participants maintains its value and its central role. Perhaps now, more than ever, patients and doctors need each other. Each needs to work in collaboration with the other if patients are to have the best possible health outcomes, and if physicians are to experience the restorative benefits of helping patients. This special relationship between patients and their physicians is essential to the AMA's ambitious goal of improving the health of the nation. And I strongly believe we must work to support it if we are to preserve the humanism of medicine. In 2012, the AMA undertook a bold new strategic direction. AMA has set out on 3 inspiring initiatives to make a deep and lasting contribution to improving the health of our nation. Over a decade, we are working to improve patient health by reducing the precursors of chronic disease, to create the medical school of the future, and to create thriving physician practices. Taken together, diabetes and hypertension affect more than 100 million Americans, contribute to over $500 billion in healthcare costs, and interfere with the healthy, happy lives of far too many. That's why the AMA is working to address these conditions before they occur. There are roughly 86 million Americans, that's more than 1 in 3 adults, with prediabetes in the United States. And 9 out of 10 of them are not even aware. Left unchecked, many of them will become diabetic and go on to have the unfortunate and costly complications related to this disease. In partnership with the YMCA and the Centers for Disease Control, AMA is hard at work to change this. The prescription is simple, really. Eat better, eat less, and be more active. It's really easy, isn't it? But it's difficult to sustain. Thankfully, the YMCA has a diabetes prevention program through which they have demonstrated they can prevent 58% of participants from progressing from prediabetes to diabetes. For patients 60 and older, the success rate climbs over 70%. At just over $400 a year, there are few interventions a physician can recommend and a patient can undertake with so little cost and so much benefit. Our partnership with the CDC Prevent Diabetes STAT, which stands for Screen, Test, and Act Today, adds to our efforts to raise awareness of diabetes and prediabetes and proven diabetes prevention programs such as the WISE that can empower patients to take action and to improve their health. AMA has also deployed its advocacy efforts to encourage government and private health insurers to cover the cost for these programs for their beneficiaries. In fact, there's legislation before Congress now to do just that for Medicare patients. Hypertension, a leading cause for cardiovascular disease, is also costing us health and money in this nation. We estimate there are about 70 million Americans affected, 30 million of whom have had health insurance and a primary care provider, but for whatever reasons are not properly diagnosed, managed, or compliant with their hypertension treatment. The reasons for this are many, but the imperative to improve it is undeniable. In partnership with Johns Hopkins and others, we intend to do just that. Working with physicians and care teams across 10 clinics, we have created tools they can use to measure accurately, act rapidly, and partner with patients, families, and communities to help control high blood pressure and ultimately prevent cardiovascular disease. As the #1 cause of death in the United States, improving cardiovascular disease and forestalling its advance is essential to the success of a healthy, happy nation. This is a big assignment, and AMA is mobilizing physicians, patients, policymakers, and payers to make things better. You can learn more about both of these initiatives at www.ahealthiernation.org. Please join us in the discussion and prevention of chronic diseases in this country. Improving the health of a nation also requires highly skilled physicians whose foundation for lifelong professional education and training is established in medical school. For more than a century, this foundation has the same essential structure: 2 years of basic science followed by 2 years of clinical experience. Though the medical content has changed as science has advanced, the structure has remained largely static. In 2012, we sent out a request for proposals to all institutions granting the MD degree. 84% of them responded. From these, the AMA is providing $1 million each to the 11 medical schools selected to collaborate with each other to create the medical school of the future. Recognizing that healthcare delivery has substantially shifted from an individual endeavor to a team-based activity, the AMA and its consortium of medical schools are transforming both the structure and content of medical education, innovating at every turn. The medical school of the future will teach the latest in medical science, but it will also innovate in the use of health information technology, team-based care models, advancing health equity, managing population health, navigating the complex financing and regulation of healthcare, and more. The medical doctor of the future will be enthused about a lifetime of learning, equipped with the education and skills necessary to drive innovation and lead within the health system to provide the best possible outcomes for physicians and patients. Now, in just our third year of this project, we are funding another $1.5 million in grants to bring on board up to 20 more medical schools to expand the learning consortium and further advance these transformational changes. Now, for the 850,000 physicians already in practice, the AMA is committed to ensuring that they have the knowledge and tools they need to deliver exceptional patient care and that their practices thrive. As I mentioned earlier, the AMA partnered with RAND Corporation in 2013 to better understand what professionally fulfills or frustrates physicians. From this research, we know that physicians are particularly afflicted by the current generation of electronic health records that waste time, don't talk to each other, and divert their attention from patients. In addition, we continue to study physician needs, reactions, and frustrations, and have learned definitively that physicians embrace positive change and want to provide the best possible outcomes for their patients. So currently, the AMA is partnering with Dartmouth-Hitchcock to better understand how physician professional time is spent in typical medical practice. This matters because we know that doctors are happiest when spending time with patients, and patients have better outcomes when their doctors are better able to focus on their needs. AMA is committed to finding ways to maximize physician time spent in direct patient care and to minimizing needless administrative burden. This commitment informs our advocacy goals at the federal and state levels and has resulted in the creation of online practice transformation modules and tools for physicians. If we want happier, healthier patients, we are going to need to have happier, healthier doctors working in partnership with them. Just last month, I had the opportunity to care for a woman in her late 80s. One of the bones in her spinal column had partially collapsed, and she was in a great amount of pain. She had already seen 2 physicians and been treated with pain medications, but they simply weren't working. In addition to her pain, her daughter was worried that something else had gone wrong. I ordered some additional tests, reassured them that nothing new had taken place, and changed her medication. When I returned to the emergency department for my next shift, a note from the daughter was awaiting me. She wrote that the tests I had run had put her mind at ease, and the medication I had prescribed had greatly reduced her mother's pain. She even included the unused refill prescription for the medication that wasn't working. Needless to say, the simple expression of gratitude and the knowledge that I had helped my patient made my day. That short note also affirmed for me that the greatest rewards I get as a physician are those special moments I spend with my patients and the knowledge that I helped them. In the future, much you currently know about healthcare will change. We will deliver care differently. We will pay for care differently. And we will use science and technology that does not even exist today to connect with one another, to preserve our health, and to treat illness. In the future, though, like today, and since antiquity, the special relationship between doctors and patients will remain at the heart of healthcare. In these times of seismic change, doctors and patients need each other now more than ever to chart a successful course. To this end, I encourage you to engage in the conversation. This can happen in your doctor's office, in your home, online, or via social media. Ask questions, be an active participant. Join the discussion with AMA at #AHealthierNation. Together, let's take charge of our health and our healthcare future to live healthier, happier lives. It's big, bold work. It's work worth doing, and it's work worth doing well. Together, in ongoing partnership, the future for patients and their physicians is bright. Thank you for the opportunity to be here today.
Today at the City Club of Cleveland, we are enjoying a wonderful forum featuring Dr. Stephen Stack, President of the American Medical Association. We'll return to Dr. Stack in a moment for our traditional City Club question and answer period, and would ask you to start formulating your questions now. Try to keep them brief and to the point so that we can get as many in as possible. And if you are joining us via our radio broadcast or webcast and would like to tweet a question, please tweet it at the City Club. We welcome all of you here and those joining us via the radio broadcast and web stream provided by our primary media partner, 90.3 WCPN, WVIZ PBS, 104.9 WCLV Idea Stream, one of the many radio stations across the country that carry City Club programs. Production and distribution of the City Club are made possible by Cleveland State University and PNC. Be sure to join us 1 week from today, October 2nd, as the City Club welcomes Janine English, President of the AARP, for a conversation on the importance of creating communities of all ages. For more information about our upcoming and past forums, please visit us online at cityclub.org. We're pleased to welcome students today at our forum. They are from Shaw High School and St. Ignatius High School, and I'd ask our students to please stand and be recognized. And remember that students can ask questions. Student participation is made possible by the Mary Jane Spar and Charles Spar Charitable Trust. Now, as promised, it's time to return to Dr. Stack for our question and answer period. We welcome questions from everyone here today, including guests. Holding the microphones today are City Club Content Associate Teddy Eisenberg and Outreach Fellow Faye Walker. First question, please.
So your comments about the physician-patient relationship were very reminiscent of those of Abraham Verghese, the author of Cutting for Stone, and I no doubt you've read that book. And it feels to me as though the recent decades have been a time when physicians have been under a lot of time pressure with respect to the time they're permitted to spend with patients. And I feel you pushing back on that. And it also feels to me as though there may have been a significant portion of physicians in practice who weren't particularly good at bedside manner and at connecting with patients. And I wonder if you could talk about sort of where we are in that arc. Are we to expect that there will be more room for doctors to spend more time with patients or to get better at connecting with their patients? And if not, why not? And if so, how can we protect that?
Right. Well, I think it's not can we, I think we must. I think we've got to find ways to make more space for doctors and patients to interact. So, I mentioned it is fundamentally a human activity. So you can look up all sorts of stuff online. If you have a disease that's chronic, you can come in and see me and be more knowledgeable about your disease than I am. And that's challenging for a doctor, right? Can you imagine that? I mean, if the patient comes in and knows more about the condition than you do, that's difficult. But not everyone responds to that differently. I don't feel challenged by that. That's fantastic, because the thing that the patient doesn't usually have, I hope they don't have it, because otherwise it means that they're chronically ill and in the health system a lot, is perspective. See, so the physician will see many patients often with those disease conditions and have context over time and context over groups of patients, not just an N of one for the one patient. So there's context, and so what you need almost, I don't want to make it sound trite, but almost a tour guide through your illness and your care. You need someone who is familiar with the system and a lot more about healthcare than the narrow slice that you've researched, and can put things in perspective and work in partnership with you. Now, some of the other points you touched on I think are very important. It's true, not every doctor is as facile a communicator as others, but then again, we've all gone to retailers, we've all gone and sought professional help for any other realm of our lives. It's true that not all human beings are good and effective communicators, and doctors are as human as anyone else. So I don't think that they are up on a pedestal because they somehow rise above their humanity in that regard, nor do I think that they're beneath any other aspect of society because they're any more deficient. So I think we want to try to provide better skills, better knowledge, better tools, so that more physicians can be more at ease and more comfortable in that communication. But in order for that to happen, they have to have time to do it. And I don't know how many other industries are represented in here from people's current or past work, but the intrusive, burdensome nature of regulations is not unique to healthcare. It's particularly crushing in healthcare. And so we have physicians pulled ever more away from the time with the patient to sit at computers and hunt and click and peck and put information in and capture all sorts of data for other people and to analyze it, determine what they will or won't pay for it, to put up barriers to patients getting treatments they need because they have to go through pre-approval processes and things like that. So we've got to find a way to mitigate some of that and get some of that out of that, because then I think most physicians are able to communicate fairly effectively with patients. Some are exceptional at it. Others are dismal at it. But the rank and file multitude of doctors generally are pretty nice people, and when we survey, most patients say they really trust and respect their physician. So I think we just need to find ways to change the environment to make it more supportive and facilitative of those human beings in that special relationship interacting with each other for the betterment of the patient. And now I think we've got some other questions. Hey, don't throw me softballs here. Let's have fun with this. I talked about what I want to talk about. This is your chance to talk about what you want me to talk about. And like I tell other folks, my opportunity is either to answer your question directly and informatively or to evade it in a way that makes you like me even more.
Robert Hobbs. Dr. Stack, there's a number of difficult problems facing medicine and society today. One of them is playing out in the state of California. On September 11th, the California legislature passed a patient right to die bill. This has now been forwarded to the governor for his approval or veto. For those who don't know what the right to die bill is, it is a bill for terminally ill patients who have no chance of long-term survival and no hope for cure, who elect to receive life-ending medications from a physician, which they take those medications themselves. The medicines are not administered by a physician. It is unclear what's going to happen in California with that bill. But the California Medical Association took a neutral position on that legislation. The AMA opposed it. Can you comment?
Sure. And that, I think, certainly meets my request to be more challenging. So thank you. So these this is distressing, not that topic specifically, but some of these discussions for the patients and for the doctors, and for different reasons, right? Because there are patients who are stridently supportive of the right, as they would assert it, to be able to have that option. And there are patients who feel that that's inappropriate. There are doctors who feel that they and their patients should have the right to pursue that course of action, and there are others who disagree with it. And it's divisive, right? So there will be no commonly shared conclusion that everybody's happy with. I mean, I just state that straight up. And it will be an ongoing journey. So most of the people in this room would know the name Dr. Gavorkian, right? So we've had this discussion before in different ways. And there's subtleties and nuances and differences to some of the stuff. But we've had this discussion. I was in Canada just last month for the Canadian Medical Association. So this presidents of the state medical associations get to go visit their neighboring states for their annual meetings. But when you're the president of a national profession, I get to visit my adjoining countries. And some of them aren't necessarily adjoining. The Atlantic or the Pacific intercede. So it's kind of a neat opportunity to see these other cultures and how they deal with this. But in Ottawa, in Canada, they passed a law that it's called physician-assisted death. And it went all the way to their Supreme Court and it was upheld. And I listened to a really enlightening debate where the leaders in their profession went back and forth just like we would in the United States about, I shouldn't be asked to be put in that, I shouldn't be put in that position as a physician. I'm here to preserve life and sustain it. And others said, I've got suffering patients who are seeking relief, and I can offer them nothing that will help them other than to relieve them from their torment. And there were compelling arguments on both sides. So the answer to your question is, can I guess perhaps comment on California Medical Association, which is its own state medical association, arrived at a neutral position. And the American Medical Association's policy is that we oppose physician-assisted death, is that we have policy-making bodies, legislative bodies, that come together, and we have about 1,100 physicians that come together twice a year to set the policies of the American Medical Association. There are over 170 medical associations represented, so all 50 states and, you do the math, 120 or so other societies that represents in the most comprehensive manner in the whole country, they're bringing together the medical profession and our policies set by that representative body from across the country and every specialty have been that we are not supportive as an association for physician-assisted death. Now, I wouldn't predict, I wouldn't prognosticate whether that will stay the same or whether that will change. It is our position on the topic. But like all things in society, society evolves with time, and we will either sustain it or we will change it. But we get together twice a year and debate those things, and I'm sure that the actions taken in California are going to be a topic of discussion at our meeting that'll happen in Atlanta this November. I'm pretty sure that'll come up in one form or another. But these are society's decisions, and so some physicians will feel challenged, because, people who pass laws and governors and legislative bodies shouldn't be able to tell me that I have to do this or not. Well, what I can say with real clarity and assertiveness is that legislative bodies should not tell doctors and patients what they may or may not talk about. I think we have to preserve the freedom of doctors and patients to talk about whatever those two people feel is necessary for their health and well-being. That's their choice. If a physician is imposing his or her opinions on a patient and they don't like it, they should seek another physician. And if a physician is overstepping other boundaries, that's different. But if a physician is counseling in good faith and a patient prefers a different approach, then those two just may not be a good fit. But then again, a patient should be able to come and ask whatever questions they want. And if a physician can't fulfill that, then they should help them find a physician who is able to provide that information. So it's about finding two people who can work together for the betterment of the patient. And that we should strive mightily to make sure doesn't get curtailed. In Florida, there were gun issues and legislative actions where they said doctors could not talk about guns with patients. And we're not trying to tell people own or don't own guns or hunt or don't hunt. That's not the point. But it is clearly and definitively proven that pediatricians who counsel family or parents about proper gun safety, securing the firearm, keeping the ammunition and the firearm separate from each other, proper education for the child saves lives. That's not offering an opinion on whether we should have guns or not. This is not a constitutional issue. This is, if we have information that will help you keep your and your family safe and alive and well, we should be able to offer that. And if that information is helpful to you, then we've fulfilled our purpose. And if it's something you prefer not to hear, that's where then I think maybe a different physician and a different patient should have a relationship. But to say that a doctor and a patient can't talk about an issue that comes up in the context of that relationship is a violation of a central tenet of the doctor-patient relationship, where we have to be able to communicate on whatever we need to help them.
Dr. Stack, welcome back to Cleveland. I believe that you were attending St. Ignatius High School when they won a couple of state football championships early in there. The
Yeah,
first two that they won,
though.
actually. Graduated, I think, in 1990, right?
Yep.
Approximately. My son graduated 2 years later. So I want to ask a question about rural health care, though. I noticed in your bio that you practiced in a rural area of eastern Kentucky for a while. And I know from having residents in a rural area of western North Carolina that rural areas are particularly challenged in health care. Hospitals are closing in rural areas more than in urban areas, probably, though they're closing every place. And particularly, insurance rates aren't as high as they are in urban areas. And the chronic diseases you mentioned are fairly prevalent. So can you address what can be done to maybe equal out the care or prevention aspect in rural areas to what it is in more urban areas?
Yeah, so this is, I love history. I studied Latin and Greek at St. Ignatius and Holy Cross. I majored in classics, and now I read that still, but I like to read presidential biographies. So you look through history, this whole issue about the disconnect between rural America and urbanized America has been around for a long time, and we're not going to solve all that. But there are things that offer some hope. So telemedicine offers the possibility of taking hard to access specialized information and make it available through technology. And I think we're going to find that telemedicine is going to grow. So there are a number of things that a hospital closer to where a person lives could provide and do quite capably and safely if they only had access to the knowledge and the information that a more scarce resource of a certain kind of specialist or team of specialists had available somewhere else. There's Clayton Christensen has written a number of books on disruptions in business and in healthcare. And one of the concepts he raised in one of his books was about separating perhaps the process from the diagnosis of care and the treatment of care. Because if you think about it, if you can get the right diagnosis and get a game plan, then a lot of people can execute the game plan. The hardest thing at some times is to find the right answer. And the Institute of Medicine just released a new report, which I haven't had time to read yet, but talking about diagnostic errors in healthcare. To the extent we can get the right answer more quickly and more consistently, a lot of other people can execute against a plan very, very well. So that may make rural health more available and more successful for more people. And then the third point I'll mention on this is just that we do have to be careful. Some of these payment policies that are getting put into place take some of these rural hospitals that have particularly difficult to treat patients because they have limited access to resource, great distances between healthcare facilities and providers, and punish through payment methodologies those hospitals caring for the sickest and most vulnerable, because they say, well, your patients didn't do as well as we wanted them to do, so we're going to withhold payment from you. But they're also dealing with patients who have challenges that are not at all like living in the center of downtown Cleveland, where you can go to world-class health care across any of a number of different hospitals, within a few small miles.
Andrew Boldy, With the increased implementation of technology in the medical field and the new generations of tech-savvy and technologically dependent medical students, do you think that the doctor-patient relationship is in jeopardy of becoming less special, as you said, or less personal?
Thank you. Well, and thank you. That's the central theme of what I was talking about here today, and I think it's so important because I think it is it is high likelihood of changing and evolving, but I don't think it's in danger any time in my life for disappearing or going away, for all the reasons I said. So you can have access to all sorts of information. If you don't know how to interpret it, or you can't put it in context, you're going to get very confused, very frustrated very quickly. I think what happens here, though, is where there was clearly a physician, the days of paternalistic medicine are largely gone. So the days of I'm the doctor, I know best, do what I tell you to, there are fewer and fewer patients who are willing to accept that approach to healthcare. And so the days of I have some problems and I think they're like this and I found this information, can we talk about this and can you tell me what you think? It's a much more collaborative kind of approach. Now that doesn't do justice to the old way because it makes it sound unfairly harsh and it wasn't necessarily, contextually speaking, but it also should not overplay that everybody comes in equally prepared. Because the vast majority of my patients are not sitting at home on their Apple Gear with T1 lines, Googling all their information all day long. Most people still come see me in the emergency department and say, it hurts when I do this, what's wrong with me? And they expect me to figure it out, all right? So there's a cutting edge of people who are really informationally savvy and technologically savvy. The multitude is heading directionally that way, but I don't think it's going to undermine the physician relationship. The other challenge you didn't touch upon is going to be the need to evolve because there's a lot more people providing healthcare now. It used to be doctors and nurses like there were two professions and pharmacists, you know. Now there is a whole myriad of different kinds of people providing healthcare, all sorts of different educational degrees with different knowledge and different skills, appropriate for some settings, perhaps not for others. And I don't think we have really gone through that as clearly as we need to about who's the right person for doing what. And that is going to require, I think, patients to be more informed because you're going to need to understand who's providing my healthcare and do I feel comfortable with what their training and expertise is. And I don't say that pejoratively because we're going to need those people to provide care because healthcare is a much more complex undertaking. So we're just going to have to find a new way to do this. But no, I think the doctor-patient relationship is here for a long time to come. But it's not going to be as rich and as fulfilling for both parties if doctors and patients don't just like a marriage. If you don't make active effort to sustain it and make it good, we should not assume that it will always be good or sustained as well as it needs to be.
I embrace your focus on the patient-physician relationship. You speak of it movingly, and it is central to people taking care of themselves. I think the respect and balance that you evoke in the patient relationship, I'm sure would also apply in your pantheon of values to the relations with the other healthcare professionals you've just mentioned. I'm married to a nurse who's still involved in the healthcare system, and though she and I have had splendid relationships with our doctors, I also hear, more from her than my own experience, some stories of what happens in hospitals and larger healthcare systems with doctors being caught up. And I think these are maybe more a bad apple phenomenon than something which is broad gauge. But doctors who really are riding a wave of excessive ego, arrogance and sexism and abuse of institutional power. And I think forces are working against that. Some of the humbling things that you just mentioned have an effect. And I would invite your comment on the forces that are working against arrogance, sexism, and abuse of power. But I specifically direct your attention to the rising number of women in the profession and ask if you think that has an ameliorative effect.
Yeah, well, ameliorative, I don't know if that's the first word that would come to mind. I think it has a complementary and a beneficial effect for sure. So there's lots of management and business school type research that shows diverse teams lead to better outcomes. So in diversity of all sorts, so you have gender diversity, you have racial diversity, you have religious diversity, socioeconomic diversity. When you have diverse teams, they tend to come at problems with a more multidimensional approach and lead to proposed courses of action that are more sustainable, generally more inclusive of various considerations, and over time more successful. And so clearly the profession has benefited from a big swing to the infusion of having women as partners in the profession. And there's more women in medical school, I think, now than there are men in medical school as a percent. It'll take a while for that to catch up in the physician practice just because of the long pipeline and training time, but clearly I think we're better for that. As far as those negative or adverse behaviors, those are clearly adverse behaviors, and they certainly exist. Anyone hear in recent news of a small automobile manufacturer who perhaps didn't do something right? So, we could go to the big scale and talk about how someone systematically who manufactures 10 million cars a year just decided to lie with all the cars they produced. So we talk about that, or we can talk about the individuals who act inappropriately. So you hear from me in my role as a leader within a profession. I mean, we don't have any tolerance for inappropriate behavior, for fraudulent or criminal behavior, for unethical behavior. We don't support that, we don't advocate it, and we don't defend people who behave that way. I will say, though, like I said in an earlier question, that I don't think physicians have any particular monopoly on that. And so when I work in the hospitals I've worked in, when I go to retail stores or I fly in the airports all the time, you see bad behavior all over the place. So the fact that it's intrinsically human, we will work very hard. I will try to set a good example so that I and others can aspire to higher ideals. But the bad apples have to be treated as the bad apples they are and either remediated or culled from the group. But the vast majority of people aren't necessarily bad apples. They're just human beings with understandable human shortcomings. Some have good days, some have bad days, but most people overall are trying to do the best they're able to within their abilities and their training. So hopefully that sort of gets at your question. I think I got time for about one more question. They said 27 after the hour.
Hi, good afternoon. My name is Sharnay, and I'm a senior at Shaw High School. And my question is, being familiar with the federal mandates that involve healthcare, do you think there could be anything done to the citizens who have almost close to nothing and as the lowest class to be taken care of?
Yeah, so there's a quote, and I'm going to embarrass myself by bringing it up and not being able to quote it accurately, but a Woodrow Wilson quote that I've used in every election I did. I ran 3 elections for the positions I had at the AMA. About it, the true test of a society is not giving more to those who have, but is giving more to those who have not. And that's a paraphrase. It's not he said it much better. But I would tend to agree with that. Now, let me bridge that maybe awkwardly, but to make a point to the Affordable Care Act. Or Obamacare. That word right there gets it, right? People who say Obamacare are usually using it as a disparaging remark, right? It's a derogatory. And then Obama in his re-election campaign said, I'm fine if you call it Obamacare, I do care, right? So he turned that right around and said, I do care. Well, it's incredibly polarizing, incredibly divisive. So I go back to a more foundational issue. In the world's largest economy, in the richest planet, or richest nation in the world, I personally find it utterly unacceptable and disgusting that we could have 1 in 7 Americans who have no access to health insurance. It is just like a sub-Saharan economy. It's cash on the barrel. You don't got cash, you don't get care. You go to an emergency department. I'm an emergency physician, and I know that. And then me trying to get follow-up for people for things is beg, borrow, steal. And I've worked in 3 different states over my medical career and seen it as an emergency physician across the country. We've got to do better. Now, if there's a private sector way to do it, then we should do it. If there's a public way to do it, then we may have to do that way. But so the Affordable Care Act, or Obamacare, is divisive because it's not a perfect law. It clearly is not a perfect law, and there are things that should be changed in it. It's not the law I or the American Medical Association would have written. But it is clearly getting millions of Americans into a system of care. Now, what it's also doing is unmasking the true cost of care. And deductibles are skyrocketing. And so what it's doing is showing people the true cost that was not really visible and apparent. And we're going to go through a real rocky point here as we recalibrate and readjust all this stuff. And the only thing I can say for certain is it's going to be a rocky ride as we go forward. But I also know that when I prescribe to a patient who previously didn't have insurance and now they're at least able to go get their prescription, they have the opportunity to be compliant. When I have someone who has a broken bone because they slipped working at a minimum wage paying job and now they have health insurance and they go get the bone fixed, they have a better chance of returning to work in 6 weeks instead of being chronically disabled and out of the workforce. So very much open to how we do it, but this is the vehicle that the political establishment in the United States offered. And I got to participate in that process, and as polarizing as it was, I'm very proud that we worked hard to try to find a way to put patients first and try to get them into an organized system of care, and now it's our obligation to try to make it better because it's not as good as it needs to be. I don't think anyone would deny that. But now I think I got you right to your 27 after the hour. It's been great to be here. Thank you very much.
Thank you very much.
Thank you, Paul. Can I step down now?
Today at the City Club of Cleveland, we have truly enjoyed a forum with Dr. Stephen Stack, President of the American Medical Association. Thank you very much, Dr. Stack. Thank you, ladies and gentlemen. This forum is now adjourned.